Hello, everybody. Good to see everybody. Um, welcome to the PLAB revision webinar. This 1 hour free webinar. Can everyone hear me? If you can, please say you can on the Telegram chat. Hi, Adam. Good to see you.
Hello, good morning, Z.
Good morning. Good morning. So good. I'm sure everybody's on Zoom. We've also got a YouTube channel that's going on as well. It's live as well. And I guess before we begin, we just want to talk about how you're gonna sort of message us, right? So join the Telegram group, right? You can find this Telegram group on your Zoom confirmation emails, or you can just type this link in, right there. We will not be using the Zoom chat. So this is the only way to communicate to us, and we will be reading your questions, and we can sometimes, if we have time, we'll answer some of your questions as well. All right, so let me introduce myself. I am Wei Zianzito. Most people just call me Z, right? That's part of my surname. I'm a GP working in central London. I founded Plabable back in 2016. I've been working in the NHS ever since then. I'm still a GP working in the NHS. My initial experience was in obs and gynae before coming to the NHS. And then even working in the NHS, I was in St. Thomas for a year, plus working in obs and gynae. And then I became a GP. I trained in palliative care and in A&E, which I really enjoyed. And I really enjoyed my entire time in training and even before training. But I think the thing I enjoy most is writing questions, right? And today, I'm still a GP, but in the evening and the weekend, I write questions for Plabable, right? I eat, sleep, and breathe Plab. This is the exam that I study the most, and I've been studying it for the last, 8 years, just studying everything about it so I can write things about the exam. All right. So now, Adam, tell us a bit about you.
I'm Adam. I'm a consultant in obstetrics and gynecology. However, before seeing the light of the best specialty in the world, I actually was a medical registrar prior to that, having completed MRCP and all that fun stuff. Now, with a little bit of Z's help, we developed the 4-day revision course that we're running a little bit later this month. We write the big mock exams that I'm sure you've heard of, that we write 4 times a year. And we run a number of webinars, or revision webinars, particularly on those topics that are really challenging. And if Z is Mr. Plab, then I must be Emperor Plab. Yeah, because I eat, sleep, breathe. The only thoughts in my life is not my children, it is about Plab. And so I'm so glad you've come to join and hang out with me and Z. And we're going to help you give a flavor of kind of what me and Z do, how we teach, how we make it interesting, and hopefully give you some food for thought.
Lovely. So we all know the PLAB exam has 180 questions to be done in 3 hours. So that means 1 minute per question, roughly. All right. So what we'll be doing today is we'll be going through some questions. We'll put a poll up as well for those who are on Zoom. You can answer through the poll. And then we will go through why we think this is the answer. All right. So let's begin.
So I'm going to bring up quite a relatively straightforward question first for you to kind of master the poll process and how to kind of meander around that. We're going to give you about 50 seconds to read the question, answer, and then we'll go through it. Make sure you've answered the question. If you haven't got access to the poll, write it down. Have a think, why on earth is it not the other answers? Are you familiar with the other answers?
All right, I'm stopping the poll in 3, 2, 1. Any poll showing the results.
Great. And that should give you an idea of how much time you have to answer each question. It's frustrating if you felt that you couldn't do it, but this is the length of the questions that you find in the PLAB exam, and you need to get used to priming your brain. So, for example, look, you read the first line, 32-year-old woman who goes to the sexual health clinic. So you're already thinking kind of gum, you're thinking sexual transmitted infections, and she's come with smelly vaginal discharge. When you start to think of smelly vaginal discharge, I want you to be thinking, okay, well, the most common cause of abnormal vaginal discharge, particularly malodorous, fishy discharge, is going to be bacterial vaginosis, but you want more information. She denies any itching or vulval soreness. And in itching and soreness and thick, clumpy discharge is going to be kind of your thrush and candida. There's stuff about the husband. Actually, this isn't going to be relevant. This is just fluffing out the question and then talking about the contraception use or not. Just because they use condoms does not mean they cannot have a sexually transmitted infection. Because she's symptomatic, you're going to do a speculum examination where it describes the discharge, which again gives you a good understanding of kind of where you're going with the question. And a thin, grayish vaginal discharge doesn't sound like the clumpy, white, cheese-like discharge of thrush or the thick, green, yellow, purulent, mucopurulent discharge of chlamydia and gonorrhea. And physiological discharge is just kind of clear or white, non-itching, non-smelly, non-irritating. And then the answer, the clincher, comes through the microscopy where you find vaginal skin cells covered in Gardnerella. Yeah. Covered in bacteria. So this is your clue cells. So plenty of kind of ways to get to that question, but I need you to go through the question in a logical manner, making sure that you're confirming your kind of suspicion of what the differential is, and then finding it and confirming it in the answers. Trichomonas, well, you'd see flagelated organisms in the microscopy. It tends to be a frothy discharge. Bacterial vaginosis, I'll discuss in a moment, but this is very typical. Chlamydia is your mucopurulent, thick discharge. Thrush is your itchy, sore, thick, white, clumpy discharge. And physiological is non-painful, non-smelly, non-itching, white or clear. And so what we do at Plabble, we love a summary slide where we put as much information on the slide as possible to help your revision needs and give you lots of clues for how other questions could be written about this topic. So I've described the typical symptoms, signs, and how it's diagnosed. And the Amstel criteria is really key, with the most sensitive clue being those clue cells, the Gardnerella bacteria covering the vaginal epithelial cells. Yeah. And then the treatment is pretty much going to be metronidazole. There's lots of ways the question could be phrased, though, as well. It could be talking about, well, what is the likely cause? And the answer is overgrowth of Gardnerella or a reduction in your lactobacilli, your kind of friendly bacteria of the vagina. Now, not a great question to start the day on, I appreciate, but it is a good question because it's quite a high yield one.
All right, next question. So you got 1 minute to answer this again. We will relaunch the poll, and there you go. Great. Stopping the poll in three, two, one, ending the poll, sharing the results. And there you go. Majority of you got that right. That's age-related macular degeneration. Now, AMD is what you're going to see in a vignette is typically a patient who cannot recognize faces and the central vision is worsening, right? So that is your AMD. Now, a lot of people get confused with retinitis pigmentosa, and the reason that they get this confused is purely because of the night vision here, which is also affected. Now, in AMD, you can get night vision loss as well when it progresses. And retinitis pigmentosa, remember, this is not central vision loss. It's peripheral vision loss, right? And the age group as well, it happens at a much younger age, 20, 30 years old. That's when retinitis pigmentosa happens. This patient's much older. You're going to be thinking about age-related macular degeneration here. Uh, I'm glad not many of you picked diabetic retinopathy or optic neuritis. Optic neuritis, you're going to get pain when you move your eye. There's an acute loss of vision. And cataracts, again, while you might have the night vision problems, you don't have the central vision loss, which points strongly towards AMD. So patients with AMD, they would look at an image and they would see this, right? It's difficult to recognize the patient. You don't know who it is, right? And this is what they would see. Oh, what a scary image. Sorry about that, guys. Gosh, gotta cover that up. Don't know what happened. Oh, there it is again. Anyway, my point here is AMD, guys, all right? AMD and not ADM, all right? Don't get confused, all right? This is AMD, not ADM. Age-related macular degeneration. Gosh, I hope you guys can sleep tonight after seeing that image. I'm thinking, gosh, I might have scared some of you. All
I have not given
right,
permission for my image to be used and abused like that. But as the Emperor of Plab, I do feel that I contribute the most to now including my face.
all right, next question. I'm going to relaunch the poll there.
Super good. So take some time, have a quick nosy at this. Yeah. People are answering very quickly, which says to me that you're not reading the question. You're just presuming because you think you've seen it before. Take some time. You've got 50 seconds. The people who answered in the first 20 seconds, I highly doubt that not only did you probably get it wrong, but you haven't properly read the question.
But I'm stopping the poll here in 3, 2, 1.
Right, so
Sharing the
over
results.
50% of you got it wrong. So it's so important to kind of read the question and make sure that you're familiar, because the questions are not exactly from the Plabbable Question Bank. They may be twisted, they may be slightly different. You need to read the question properly. So look, a 56-year-old comes in with shortness of breath and chest pain, yeah? Recently had an operation. So you've got risk factors for a pulmonary embolism, yeah? And she's been immobile. High respiratory rate, borderline saturations. You do a chest x-ray because the alternatives may be a pneumonia, maybe a pleural effusion, maybe a pneumothorax, and that's normal, which you would find in a pulmonary embolism. An ECG is indicated, and what is the single most likely, what is that most prevalent finding on an ECG in the context of pulmonary embolism? And the answer is by far sinus tachycardia. So this S1Q3T3 happens in less than 5% of cases, usually a very large saddle embolus, and is super rare. It's unlikely you'll see it in the majority of your careers. Sinus tachycardia by far. And I'm afraid to tell you that this is a very easy question. And so take this as a learning point that very uncommonly is S1Q3 a T3 going to be an answer. It's not an ECG that in the PLAB exam they will bring up, but sinus tachycardia is by far the most common finding. So when it comes to investigating a pulmonary embolism, we've already talked about, look, clinical assessment, observations, ECG, chest x-ray, an arterial blood gas if hypoxic, and then the gold standard assessment is going to be imaging, which is a CTPA, a CT pulmonary angiogram. That allows me to see the direct thrombus. Go back, see you Fruit Loop. That allows me to see the exact thrombus. And if there is no thrombus, it may help me see other pathology. A VQ is an alternative but less readily available modality. So when you're asked about the gold standard of diagnosis of pulmonary embolism, it's going to be CTPA. A VQ scan requires a normal chest x-ray and no respiratory disease and no significant smoking, because what you're doing is comparing the perfusion of the lungs to the aeration of the lungs. And so if they're unable to take a deep breath or have a restrictive or obstructive lung disease, you may have an inappropriate mismatch. In pregnancy, it's a little bit different. If you suspect a PE or a DVT, then again, you do the same thing. Clinical assessment, observations, ECG, chest x-ray, yeah? Now, a chest x-ray is completely safe in pregnancy. You don't need to shield the abdomen or anything silly like that. And the reason you're doing a chest x-ray is to rule out the things I've just mentioned for a PE outside of pregnancy. Pneumonia, pneumothorax, pleural effusion, yeah? If there's a stonking evidence of a DVT, so they've come in with some chest tightness and some pain with palpitations, but they've also got a big swollen leg. Actually, do a Doppler first of their leg, an ultrasound, because if you find a DVT in their leg, then of course it's very likely if they have chest symptoms, they also have a PE, and you don't need to irradiate that patient. Yeah. But if they have no signs and just have normal legs, because the majority of embolizing DVT in pregnancy occur in the iliac and femoral veins much higher up, then what you need to do is definitive imaging. And the challenge is that there's no guideline that tells you to choose VQ or CTPA. Yeah, it says either one is appropriate in pregnancy. However, As you can imagine, in pregnancy, with the enlarging and kind of high turnover of cells within the maternal breast, doing a CT scan in pregnancy can increase women's lifetime risk of breast cancer, although that's a very small risk. A VQ scan can increase the risk of cancer in childhood of the baby because there's a higher rate of radiation to the baby. The risks are very, very small of both of these issues. But because when it comes to pregnancy, that the mother is your main priority, I would recommend choosing a VQ scan in pregnancy if you have to choose for your definitive test. Yeah. In the context because it hasn't got an increase in the risk of breast cancer in the woman compared to a CTPA. Now, of course, that's in the context of a normal chest X-ray. If you have an abnormal chest X-ray or respiratory disease, then you're going to do a CTPA. So just to run through that again, if there's signs of a DVT, check the legs. Do an ECG, an X-ray to rule out any other causes. And then if you have to choose, use a VQ scan if their chest X-ray is normal to confirm there's a PE.
All right.
And then, sorry, low molecular weight heparin is the treatment of choice in DVT and PE in pregnancy. We do not use warfarin in pregnancy, and we do not use DOACs like rivaroxaban.
Fantastic. All right. So our next question, I'm going to be giving you 2.5 minutes to do because you need to calculate this one. So 2.5 minutes, everybody. Almost there, guys. All right. I'm going to stop the poll in 3, 2, 1. Sharing the results. As you can see, not many of you got this correct. The answer is E. Now, epidemiology questions are very hard only because of time, right? So, can you do it in 1 minute? Probably not. Yeah, you cannot do epidemiology calculation questions in 1 minute. You need 2.5, 3 minutes sometimes. And for that reason, all your other questions need to be even quicker to answer. 30 seconds, 20 seconds to answer those questions because you got to leave room for your epidemiology questions. Now let's go back and understand what NNT means, number needed to treat. So firstly, let's not even talk about the definition. Let's talk about the formula here. NNT equals 1 divided by ARR. And your ARR is your absolute risk reduction. So the first thing you need to get is your ARR. Don't care about the NNT. Let's focus on the ARR. What is the ARR? It is the absolute risk in the control group subtracted by the absolute risk in the treatment group. So back to the table in the question, you have here the placebo group, which 20 people out of 100 develop COVID, and then the people in the drug group, only 18 out of 100 develop COVID. So if you think about it this way, the absolute risk in the control group is 20 here divided by the total of these two numbers, which is 100. And then you're going to get 0.2. And the absolute risk in the treatment group is 18 divided by the total of people in that group, which is 100. So you're going to get 0.18. Now, if you subtract that, you get 0.2 minus 0.18, you're going to get 0.02. Now, you're not done yet because that's just the ARR. Now, you got to put that into the formula, 1 divided by 0.02. And again, you cannot bring a calculator into the exam. So you just got to use your head and remember that 1 divided by 0.02 is 50, right? Majority of you will be able to calculate that. But if you struggle with that, if you think it's too hard, then perhaps maybe, times it by 100. So, 1 divided by 0.02, you times both numbers by 100, you get 100 divided by 2. Now it's a lot easier, isn't it? 100 divided by 2 is 50. So what does this tell us? What does this number tell us? 50. So number needed to treat is the number of patients you need to treat using that one medication or that one intervention to prevent one additional bad outcome. So this means that I would have to give 50 people this new medication to prevent one person from getting COVID. Does that make sense, everybody? That is your definition of NNT. And you need to remember the definition. You also need to remember how to calculate NNT for the exam. So I hope that this sticks with you and we can move on to the next question, everybody.
Right. So the next question is going to be your nice guidance on antihypertensives.
Great. I'm stopping the poll here in 3, 2, 1. And in the poll, sharing the results.
So when you get a hypertensive question, there's a few elements that you need to try and tease out in the exam. The first one obviously is going to be the age, the ethnicity, and whether there is any pre-existing diabetes. And the first question you ask yourself when it comes to hypertension is, are they diabetic? Do they have type 1 or type 2 diabetes? If that is the case, regardless of their age or ethnicity, you're going to give them an ACE inhibitor. Now, actually, there's a correction to that, that if at any point you want to offer a Black Afro-Caribbean patient an ACE inhibitor, you're going to give an ARB, an angiotensin receptor blocker like losartan. So, first question, are they diabetic? The answer is yes. So you want to give an ACE inhibitor. Are they Black Afro-Caribbean? No, they are not. And so you give ramipril. If they have type 2 diabetes and you think, I want to give them an ACE inhibitor, regardless of the age, but they are Black Afro-Caribbean, you're going to give an angiotensin receptor blocker because Black Afro-Caribbean patients tend to have a lower renin and therefore less responsive to ACE inhibitors. If they are not diabetic, then it comes down to age and ethnicity, doesn't it? This patient is over 55 and so would be offered a calcium channel blocker if they didn't have type 2 diabetes. And so I think I have a good slide summarizing it here. Oh, it's just the nice guidelines that look, hypertension with diabetes, without question, I'm not interested in their age. It's an ACE inhibitor, or if they're Black Afro-Caribbean, an angiotensin receptor blocker. Take out the diabetes. It's all about are they under 55 and not Black Afro-Caribbean. It's an ACE inhibitor. Unless they are part of the 15% that develop a dry cough, then you go to an angiotensin receptor blocker. If they're over 55 or Black Afro-Caribbean and have no diabetes, then you offer a calcium channel blocker, with your second line being an ACE inhibitor. Unless they are Black Afro-Caribbean, then you go to an angiotensin receptor blocker. So those are the kind of rules you need to get into your brain. Diabetes, ethnicity, and age.
Lovely. So I love how Adam's teaching hypertension.
I'm a jack of all trades, Mr. Emperor of Plab. While GPZ, Z the GP, teaches you on hemorrhoids, back pain, and some eye problems. I'm going into the depth of the good stuff. So, just some special considerations, because this is what catches out Plab candidates from our experience. The first one being that like anyone with diabetes or significant proteinuria, an ACE inhibitor, unless they are Black Afro-Caribbean, for which you give an angiotensin receptor blocker as first line. If there is an element of heart failure and you get to the point of an algorithm where you're offering a calcium channel blocker, offer a thiazide diuretic instead. So, for example, somebody who is 50 years old and hypertensive with heart failure, I'm going to start with an ACE inhibitor because we know ACE inhibitors help with the remodeling of the cardiac function. The second line treatment of hypertension in a 50-year-old is going to be a calcium channel blocker, but not in heart failure. I'm going to swap that for a thiazide. So in the context of heart failure, it's a swap a calcium channel blocker for a thiazide rather than choosing thiazide over everything else. And in pregnancy, the first line treatment is going to be labetalol, which is a beta and alpha antagonist, but we cannot use that in the context of asthma, like any beta blocker, because of the risk of flaring the asthma. So your second line treatment or your first line in those with asthma is going to be nifedipine.
Lovely. So I'm just looking at the Telegram group to look for some questions here, and someone's asked about why, Adam, did you include the magnesium sulfate here in this question?
I don't believe this is actually my specific question, but I think how funny I suspect is that this used to be a pregnant patient and then has now morphed as we tinker with the questions to a 57-year-old man. However, unfortunately, Z has full reign of my questions and he commonly puts mistakes and errors to make me look silly. And so I'm just from the bottom of my heart, I apologize for Z, Mr. Plabbable.
I just thought, this might be a question that Adam drafted, and then he thought, you know what, I need to think of some drugs to add in. And, Adam being the obstetrician only knows like 4 or 5 drugs, magnesium sulfate being one of them for eclamptic patients. And he's like, oh, yeah, I'm going to throw in magnesium sulfate there. And there you go. This
I
question
mean,
is coming up
clearly
like
this
this.
was an asthmatic or a Yeah, it sounds like an asthmatic question here. But as I say, yeah, as an obstetrician and gynecologist, I've given clotrimazole, metronidazole, and done a smear.
Very good, very good. All right, next question, everybody. All right, gonna stop the poll here in 3, 2, 1. Sharing the results. Yes, everybody. In this case, you arrange a meeting to discuss the patient's best interest. So this patient, this 32-year-old woman, lacks capacity. Now, she lacks capacity for this one intervention, right? Which is giving her iron tablets. She's not compliant. She's anemic. So this is a problem. So what's the most appropriate action here is to have a meeting, not just with the other healthcare members, but also with the family to decide what should we do in this case. Should we force it down her throat? Should we say, okay, don't take it? Should we perhaps maybe give a Mirena coil to prevent menorrhagia? Should we give IV iron? Should we give, should we just tell her to eat more iron in her diet? There's so many things that you could do, right? So the point here is it's important to involve the family. Everybody comes to the table, thinks of a solution that will help this patient and go from there. And if any reason that everybody says, no, I can't agree with you, I don't think giving her IV iron is appropriate. I don't think increasing her dietary iron would suffice. I don't think that putting a Mirena coil would be good for her. Or what if they cannot agree? The healthcare professionals and the family, or the healthcare professionals and the other healthcare professionals all cannot agree. That's when you involve an independent advocate. This is someone that working in the NHS who comes in, who has no connection to the family, no connection to the healthcare professionals, and just sits down on the table and says, give me all the information. I'm going to help decide based on my independent review, not based on my feelings from the family, not based because I know the healthcare professional very well, etc. That's your independent advocate. And again, if that fails and everybody doesn't reach to a consensus, then you involve the court for independent ruling. I've never seen number 3 in my career. Number 2 I have, but number 3, no. So it's very, very rare. And then now we go on to our next question.
Okay, so this is a 16-year-old girl who's wanting emergency contraception and she's having sex in a class her parents don't know. Let's just launch the poll.
Launching there. Oh, wait. There we go. All right, we're going to stop the poll in 3, 2, 1. Stopping the poll.
Good.
Sharing
So
the result.
I'm really reassured that this question didn't catch you out. So remember, the age to have consensual sex is 16 and above. And so from a legal point of view, a 16-year-old and above can have sex with any age above 16 as long as it is consensual. The points that you're going to be obviously looking out for are people under the age of 16 having sex, the age of what their partner is, and by saying a boy in their class, it usually means a similar age. And obviously, you're also looking out for red flags, such as are they having sex with people who are either significantly older or people in positions of trust, like doctor, carer, teacher, support worker, something like that to suggest that this is not appropriate. So the kind of rules that you need to remember is anyone having sex below the age of 13 doesn't mean if they're doesn't even matter if they're having if two people under the age of 13 are having sex, it is important to escalate straight away to child protection, safeguarding officer, whatever the phrase is used, but it's safeguarding referral, who may then go on to inform the police. But you, as a doctor, very rarely will inform the police directly. Yeah. So that is not the correct process in the context of two significantly underage children having sex. Yeah. Or one under having sex. Between the ages of 13 and 16, it depends if somebody who is under the age of 16 is having some sex with somebody who is over the age of 16, that is not appropriate. If two people who are, say, 15, 16 having sex, you've got to assess whether this is appropriate. Is there any other kind of red flags here? And you've also got to be thinking, are they having sex with anybody who is in a position of trust, as I've mentioned? So the next slide kind of summarizes that a bit nicely. So you have to be 16 and above to have sex. If they're over 16 and their partner's over 16, enjoy having sex, no issue in the PLAB exam. Between 13 and 16, you want to make sure that the Fraser guidelines are adhered to. They cannot be convinced to tell their parents. They understand the ramifications of having sex and are at a level of maturity to make that decision, that it is consensual and that they're having sex with somebody of an appropriate age to them. Of course, anybody, teacher, doctor, carer, support worker, or anybody in a position of trust, safeguarding, and anyone under the age of 13 having sex, again, unacceptable, needs to be escalated. And so it really is barn door, these questions.
All right, next question, everybody. All right, stopping the poll here in 3, 2, 1. Sharing the results. And so your answer is B. What 50% of you got that right, and 30% of you marked C as the answer. And I know what you're thinking here, but let me go through this entire question with you. So this patient is having a fever, has a stone, has hydronephrosis, and has AKI, right? And you know that because the creatinine is high, the eGFR is low, and this is an acute presentation. So the reason why we do a ureteric stenting first is because the priority is urgent decompression of the urinary system. The priority is not to remove the stone. The priority is to remove the urine because the urine is going to make the patient septic and die. So your priority is do whatever you can to remove the urine. The two main ways to do this, especially if the stone is up the right distal ureter. Well, in this case, the best way will be a ureteric stent. The other option is a percutaneous nephrostomy, and I'll show you an image about that as well. But the idea here is that with the ureteric stent, you're putting a JJ stent, which bypasses the stone up to the renal pelvis so that it drains the urine out, bypasses the stone, and comes out. And the stone can be left there. There's no urgency to remove the stone. We could remove it in 2 weeks' time, in 3 weeks' time. That's fine. The idea is to use the emergency theater to quickly remove the stone. And the theater staff, they're trained for emergencies. They can quickly do a ureteric stent with the urologist, right? And then they can bring in the next patient who is a AAA or an ectopic pregnancy or whatever. If you spend too much time trying to remove the stone in an emergency theater, you're delaying another emergency, right? So don't ever do that. You want to just remove the urine, book him in for an elective surgery 2 weeks later, 3 weeks later. This gives time for us to give antibiotics to help with the infection. It also gives time for the ureter to not be so swollen anymore, right? To calm down a bit. Then you can take out the stone later on with a percutaneous nephrolithotomy. So again, to recap here, when to pick ureteric stenting and percutaneous nephrostomy. You pick either of these options when you have a patient with a stone, obstructive uropathy, fever, or AKI, right? Decompressing the renal collecting system should be the first thing you think of. And then later on, you think about how to remove the stone. Now, the common mistake that people make is confusing these two terms, percutaneous nephrostomy with percutaneous nephrolithotomy. And I guarantee many of you who made that mistake did it today in this question, where you thought this is the same thing. But no, a nephrostomy is the artificial opening. This is where you put in a tube cutaneously into the renal pelvis and you drain the urine. Whereas a lithotomy is where you suck out the stones. These are done by interventional radiologists as opposed to urologists, and it's done under local anesthesia. Whereas ureteric stenting is done under GA, so you need to use the emergency theater for this. All right, but in whatever case, if you have AKI, fever, obstructive uropathy, and a stone, you're picking either a ureteric stenting or percutaneous nephrostomy. Either or, that would be a good choice. All right, everybody happy with that? Let's move on. Stopping the poll here in 3, 2, 1. Sharing the results.
Right. So someone turns up to the fertility clinic, unable to conceive with irregular periods. And so your irregular periods, the most common cause is going to be your kind of polycystic ovarian syndrome. And this kind of fits well with her being overweight, oligomenorrheic. And then, interestingly, dark pigments on her neck, which is acanthos nigrans, associated with insulin resistance and obesity. She's receiving laser for unwanted hair on her chest. And I'm saying that because there is clearly male pattern hair growth. Blood tests reveal a high LH and high testosterone. So I've really kind of guided you towards a PCOS kind of picture of kind of oligo menstruation and ovulation, evidence of hirsutism and raised testosterone, and then an ultrasound will find a polyfollicular ovaries. Salivary cortisol is a consideration if you're thinking that this is Cushing's syndrome, but commonly in that you'll also get the striae, the buffalo hump, the hypertension, the easy bruising, all fun stuff like that, which is evidenced here. And also you tend to get a low LH and FSH and low testosterone in Cushing's. Semen analysis, well, although that is part of your clinical examination of the couple, this is very much focused on the woman here. There's no indication for an MRI pituitary. That should not have been an option. And prolactinoma is not going to give you acanthos nigrans, is not going to give you male pattern hair growth, and is absolutely not going to give you a raised LH or testosterone. So although I think you chose prolactin because the irregular periods, there's literally nothing else to suggest that would be the indication. And so I'd question whether you'd read the question properly there. So the diagnosis of PCOS is usually done by meeting two of these three criteria. A pelvic ultrasound is absolutely essential to rule out other causes of irregular periods or irregular bleeding, but the key signs will be polyfollicular ovaries, ovulation or menstruation being irregular, and evidence of hyperandrogenism, usually with high testosterone, particularly the free androgen index, and evidence of significant acne and facial hair. Now, what also comes up in the PLAB exam is the treatment. And it really depends on what the woman's symptoms and problems are. For example, if the problems are irregular periods, so it's not fertility, it's just irregular, unpredictable periods. It's weight loss, weight loss, weight loss, weight loss, weight loss. And if that's not, if she needs some help with regulating a cycle, you can start her on the combined oral contraceptive pill to give her a regular cycle. Metformin has absolutely no indication in this context. There is no guideline in the UK where metformin is indicated for menstrual irregularity. If in the context of this patient, such as management of fertility, it's weight loss, weight loss, weight loss, weight loss, weight loss. If they're still struggling, you can give a ovulation induction agent such as clomiphene, a selective estrogen receptor modulator, for 3 months. And if that doesn't work, you can then add on, with permission of NICE guidelines, to add in metformin. You must never give metformin alone. It's never going to be the answer in the PCOS questions. Leave metformin alone. It is not the answer in PCOS.
So guys, we are reaching our half time. We have one or two more questions to discuss. But before we discuss those two questions, we just want to talk about our course, which is coming out end of October. And Adam does a great job discussing this. Adam, take us away.
Yeah, so this is our baby. We've developed this 4-day mega course where we have intensive lectures, interaction, revision trips, and we kind of teach it like this, but a bit more detail, where you get me and Z bouncing off each other, sharing stories, sharing ways that candidates have previously tripped up or struggled. And what we're really proud of is it has not only excellent feedback, we have a very, very high pass rate because we create a network of people in the same situation. We share difficult situations. We share difficult questions. We share ways to beat the PLAB exam. It creates a family of support. And we're running the next one online between the 24th and the 27th of October. And it's bloody brilliant. It's always good fun. In addition, we write a new big mock for the revision course where we write 180 questions specifically for a new big mock. So these questions aren't on the Plabbable question banks. This is a never before seen questions which are either fresh or have been tinkered with or played with to give a completely different experience. And the good thing about being the first one to read the big mock is that no questions have been spoiled and you get a good experience of, oh God, what's it like taking an exam that I haven't seen the questions before? Yeah. And so 4 days of intensive revision as well as the new, fresh, big mock exam straight from me and Z's brains. It comes with a specific WhatsApp group where we can create a family of revisers, where we can help each other out. And these are friends who are going to be going through PLAB with you. So it's good networking. We give you time to answer questions. We give you time to ask questions. We make ourselves available to you. It is not recorded though. This is, you have to be there to experience it. And that's because it gets lost in translation if you start recording things because it quickly becomes out of date for future reference. And also the experience of being on the course is part of it. We do give you a full set of lecture slides, though, fully annotated, lots of juicy stuff to help you revise. And let me tell you, look, doing the Plabbable question bank, doing the 4-day revision course, doing a few big mocks, that's how you get through the exam. Well, the teachers on there, so you've got me and Z, but we actually bring in some other experts as well, such as a consultant in acute medicine who's amazing at talking through arterial blood gases, chest x-rays, nephrology, really challenging bits of information. And then Zin talks, our neurology senior registrar, talks about different brain areas, optic tracts, all fun and complicated stuff, stroke localization. It's bloody brilliant. And so just be mindful that we bring in the experts to teach this course.
Yes. So the course is absolutely brilliant. And I've been thinking about what's a bigger disadvantage of the course. And to be honest, I can't think of any, except that you would have to look at Adam's face for a period of time. But it's okay because you can cover your screen with a tissue paper or something like that, and then you're good. You're good to go, right? That's the only thing I could think of. But you know what? Jokes aside, Adam is actually a great teacher, and I've been working with Adam for 8 years now, and I can see how he's been teaching. And if you look at today's webinar, and I don't want to make his head too big here, but if you look at today's webinar, he hasn't even touched an obs and gynae question. All he's been touching is GP questions. And I'm thinking he's doing a pretty good job here, right? So jokes aside, Adam's doing a great job. Just cover his face with a tissue and you're pretty okay then. Now, the flammable question bank. We have now about 4,500 questions. The idea here is don't memorize the answers. Read the explanations, trying to understand the questions here, right? We still got a couple of questions we want to discuss, but I want to make sure that you know what to do for your prep for your exam. Because we are not the only good question bank out there. There are lots of other good UK question banks out there that you can subscribe and do as well. But what I'd say is always look at the About Us page because you're looking for registered doctors who are, GMC registered doctors, right? And you want the company to be registered in the UK because if the company is registered in the US or somewhere else, then you're going to be wondering, are they really catering for a UK exam? And you know this because you'll be paying in pounds. If you're paying in pounds, it's likely going to be a UK registered address, UK registered company, like Plebable, right? If you're paying in USD or something else, then you got to be thinking, gosh, am I putting money into a company that doesn't really focus on the PLAB exam? So those are the two top tips I want me to take home when you find a question bank, aside from Plebable, right? And why is this important? Because a lot of question banks outside of the UK might try to steal information from UK question banks, and they often teach the wrong thing. And then Adam and I spend a lot of time trying to recorrect your thoughts there, your ideas there, right? And outdated information is copied out. of our question banks and used in some other question bank. And then we spend a lot of time trying to reteach you this. So remember those two tips. Now, let's discuss our bonus question here. So here we have a 64 year. Oh, let's do a poll here. What am I doing? All right. I'm stopping the poll here in 3, 2, 1. Ending the poll, sharing the results. A is your answer, right? An SGLT2 inhibitor. Majority of you got that right. And the idea here is you're looking at the fact that he's diabetic. His HbA1c is right at the border, 58. That's when you would intensify treatment. So you add in another diabetic drug. But the drug that makes the most sense would be the one that is renal protective because he's also got CKD, right? And so an SGLT2 inhibitor makes the most sense. If you look at the polls, majority of you picked the right answer. Some of you picked C as the answer. And obviously, angiotensin converting enzymes would be appropriate as well. But he's already on it. He's already on ramipril. All right. So no point starting a second angiotensin converting enzyme, right? Just leave that. Go with an SGLT2 inhibitor. Now, people often worry, they say, oh, no, SGLT2 inhibitors, are they effective with low EGFR? And yes, you're right to say SGLT2 inhibitors are less effective for the diabetic management if the EGFR is lower. But that being said, you're not just using it for lowering the HbA1c. You're using it because it's renal protective, because it's cardioprotective. So you might start an SGLT2 inhibitor and repeat his HbA1c in 3 months and say, hey, actually, now that we've started this and still not well controlled, let's add on another diabetic drug, right? But you still would start this knowing that it's good for the kidneys. Renal protective. The patient's HbA1c here is 58, indicating suboptimal glycemic control. An SGLT2 inhibitor would not only help lower his glucose level, but also protect his heart, also protect his kidneys. All right, everybody. ACE inhibitors are important too, as well. You would also add that on, but he's already on it. All right, everybody. So that's our last question. Now, there are a lot of Telegram questions that are being asked, and I've seen them. Now, because of time, we aren't addressing them on this webinar, but what I'm going to do is I will be doing voice messages in the next 5 to 10 minutes, answering all your questions on Telegram, so that you'll be able to hear the explanations that we are doing as well. All right. Now, before we go, Adam, walk us through what are big mocks and do you need to purchase the course for a big mock?
Oh my goodness, oh my goodness. So, as I said, me and Z will write a fresh new big mock for the revision course, the 4-day revision course. Now, we will be offering the new big mock as a separate purchase if you so wish and cannot attend the course. However, the benefit of the course is that we do a live run through of each question in the new big mock, which you would not get by just purchasing the new big mock after the course. So you just need to bear that in mind, that actually it makes more financial sense to be part of the full course where you get the new big mock and the live discussion. But we do offer the new big mock and some of our older big mocks as a separate purchase if you so wish. And that can be done through the website. What we do is we keep the previous last two big mocks, last 2 years of the big mocks for good revision, because actually having a number of new mocks to practice with is really useful. And so I think hopefully that answers the question.
Lovely. All right, everybody. So I will continue on answering some of your questions on Telegram by doing voice messages. But otherwise, thank you for joining us. Good luck. Any questions, please email us. Adam, any last words?
No, good luck, everybody. Thank you for joining. And I do hope that you consider some of our other additional resources because it's very rewarding working with plabbable candidates that have come through the system and come to the UK to work with me and Z following successful plabbable revision.
All right. Bye, everyone.